Thanks, Jean. As mentioned, I'm Heather Marie, and I'm going to share an update on PrEP in our region. It's been a decade since WHO made its first conditional recommendation on oral PrEP. Since 2015, WHO has recommended oral PrEP as an additional HIV prevention option for anyone at substantial risk of HIV as part of combination HIV prevention approaches. There is high-quality evidence from clinical trials, open-label extension studies, and real-world implementation that shows that oral PrEP is highly effective, and that applies equally to daily dosing regimens as well as to event-driven, also known as on-demand, ED, or 211 PrEP dosing regimens. However, effectiveness is also highly correlated with adherence. So the key message here is that PrEP works, and it works well, but only if you take it. Large-scale uptake as part of combination prevention and on the back of high testing and treatment coverage has been associated with population-level decreases in new HIV infections. And this has been seen in places like Australia, England, Scotland, cities in the US such as Seattle and San Francisco, and others, where they have achieved really high levels of uptake, but also typically have done so fairly rapidly. And this has really interrupted HIV transmission within populations, leading to those decreases. And this really shows that benefit of PrEP over and above individual protection. One of the things that we haven't spoken very much, or we don't speak very much about, is that PrEP is also empowering for an individual and has psychological benefits, which include reduced shame and fear. These are really important, and I don't think we emphasize those enough. The UN also recognises PrEP as an important HIV prevention tool and has included it in the political declaration as well as the new global AIDS strategy, and it is an integral part of the UN 2025 targets for 95% of people having access to comprehensive prevention approaches. And so looking at our region, PrEP is really important. In the Asia and the Pacific, there were an estimated 240,000 new infections in 2020, a decline of only 21% since 2010. But this figure hides significant variation by country, but also by populations within countries. Some countries have experienced declines, including Vietnam and Thailand, while others have rising epidemics, including Malaysia, Papua New Guinea, Pakistan, the Philippines. Overwhelmingly within our region, the epidemic is concentrated among key populations and their partners, who accounted for 94% of new adult infections. Critically, key populations are underserved by national HIV prevention programs, and often the available programs are reliant on international donor funding. These programs typically have suboptimal coverage, and they contribute to continuing inequity, particularly in cases of criminalization, persistent stigma and discrimination. The situation is particularly acute for young people. While young people accounted for only 6% of people living with HIV, they are accounting for increasing numbers of new infections. And in 2020, almost 1 in 4 new infections was among somebody aged 15 to 24 years. Young people, and I'm going to say young members of key populations, are typically even more poorly served by existing programs, which, where they are available, are often designed for the needs and the preferences of older adults. Young people often have poor access to sexual health education and may not meet their unique needs, particularly for HIV prevention. And the laws may restrict access to HIV testing, PrEP, and other services. Where laws do not restrict access, clinicians may still be reluctant to provide these services to minors. However, we are seeing an increasing momentum for PrEP being available in countries within our region over the last 3 or 4 years. Countries such as Thailand, Vietnam, Cambodia, and Nepal are all in the process of scaling up their programs, as is the Philippines. And a particular feature is the access points and the diversity of those access points in clinics. As you can see here, most of the countries are, however, in earlier stages of PrEP implementation, with new programs starting in places like Bangladesh, Indonesia, India, Pakistan just last week. And access may be limited to demonstration projects, to certain geographical areas, quite often big cities or a capital city, and or the private sector. What this means ultimately is that there are only a small proportion of the people who might otherwise benefit from PrEP as an HIV prevention choice are able to get it. And you can see this when we look at the expansion of PrEP programs in terms of the numbers of people who are accessing PrEP. There are undoubtedly more people than ever who are accessing PrEP within our region. However, Asia and the Pacific accounted for less than 10% of PrEP users globally in 2020 and about only 2% of the 4 million person target for 2025 for our region. What's really critical here is that the number of PrEP users is not proportional to incidence within any country, to prevalence, to PrEP need, and is not enough to affect the course of the epidemic in any country except for Australia. And this is a particular concern with those rising epidemics across our region. Remembering it's been a decade since that first conditional recommendation and 7 years since the strong recommendation from WHO, and that we need to really not have demonstration size projects of a few hundred or a few thousand people, but we need to roll it out at scale to achieve an impact of interrupting HIV transmission. So let's look at some case studies from within our region and the lessons that have been learned. Thailand began providing PrEP as part of a demonstration project in 2014 and is one of the first countries worldwide that provided PrEP. Their program, of course, has evolved and expanded over this time, but one key achievement I would like to highlight is that they formally integrated PrEP within their universal health coverage or their national program in 2021. This process started in 2019, but was completed in 2021. And this has supported the expansion of PrEP overall, but also within the public health system, as well as community and key population-led services. There are now more than 16,000 people who are using PrEP, up from 3,000 just 2 years ago, and 80% of the people who access PrEP do so via key population-led services. Key population-led services are led by lay providers, and they have been instrumental and somewhat synonymous with the Thai approach in creating available, accessible, and acceptable and differentiated services that are designed to meet the needs of key populations of communities. Critically, these services are now reimbursed by the national health system, and there is an accreditation process. So they are embedded within that national response. Another thing that I want to highlight, because there are a lot of things I could talk about with Thailand, but just one more thing, is around their innovation. And so there are two things with the innovation, not just the key population-led clinics, which is an amazing innovation, but it is an older one. But during COVID-19, they really tried to improve service delivery. So this included shortening clinic visits, using self-sampling for STIs, mobile drug delivery, digital health, and also switching their entire messaging from risk-based kinds of messaging to much more gain framing messaging to raise awareness and to really give people much more of a need for PrEP. A short note on the key population-led services. So these deliver the full range of services required by PrEP users. In these services, an individual comes into a key population-led clinic. As I mentioned, these are run by key population, so peer lay providers without a doctor or a nurse on site. An individual receives the blood draw and their HIV test using a 4th generation rapid test. That negative test result is shared with the doctor via an online chat application. The doctor can then review and approve the PrEP prescription back by that same application. And then the lay provider is able to dispense PrEP as an initiation or as a follow-up. And it's almost always within 1 hour of the client presenting for that initial HIV test. So what's really important to highlight here is that the client never sees the doctor or the nurse. That interaction is managed by the key population-led provider. And that peer is really able to increase the acceptability, the accessibility of these services. Vietnam has a lot of innovations, and I had an entire other slide that I don't have time to share with you, but I wanted to highlight one important case example. Vietnam is in the process of scaling up their programs, and they have over 26,000 people, I think, last year on PrEP. However, they have really recognized that there are certain places and certain populations who are really underserved by the existing programs. So in last year, they introduced a mobile PrEP service to better complement existing services and to meet the needs of these underserved populations who may experience barriers to accessing services, particularly maybe unable to get from where they're living or working to where a clinic is located. The teams in these mobile services include physicians, nurses, counselors, pathologists, and also peers. This is really important that there is a multidisciplinary team. And they provide a range of services, including HIV and STI testing, counselling, assessment for and provision of PrEP, of course, as well as STI treatment and referral to other services. So far, they've been launched in 4 provinces, and they have really supported increased uptake of PrEP, as well as have supported continuation on PrEP, and will soon be expanded as demonstrating how well they have been received. In the Philippines, PrEP is beginning to expand more rapidly, and I've included it here as an example of what can be done by clinicians and civil society. The CBO Love Yourself originated PrEP with the Project Preppy pilot project, and their model and their current model really uses a friendly community-based setting and prioritizes task sharing with peers with activities like PrEP information, counseling, and eligibility assessments. During their expansion phase, they took even more differentiated and client-centered peer-driven approaches. And this included streamlining consultations, and I mentioned this also around Thailand. What a lot of providers find is that once they become much more confident in prescribing PrEP, they can really reduce the amount of time that a client needs to spend, and they find much more efficient ways of delivering PrEP. They also increased or expanded access points. So one of the really cool things that they've done is that they have really leaned into online spaces in digital health. So they can have their initial consultation with the counselor and with a doctor online, attend a diagnostic facility to have their necessary tests, and then, if necessary, have a follow-up with a doctor or a counselor, but also have their medication delivered to them. So somebody doesn't actually need to attend a clinic. And this has been really important where accessibility has been an issue, and this particularly obviously COVID-19. There are many other times where somebody is unable to attend a clinic or take the time out during clinic opening hours. Honestly, there are so many other great examples from within our region that I would love to share. But what I would like to do right now is to highlight something that we've seen from many countries within our region, and that is that shift in demand generation. Demand generation has been largely led by community organizations, and the campaigns, and you can see these here, there is an increasing trend for positive, empowering, and fun and sexy messaging. And this is helping to normalize PrEP as part of a suite of options that's available, and to reframe conversations, both clinical and in the community, away from risk and towards benefit. And this is hopefully helping to reduce stigma and discrimination and to reduce fear. So to very quickly summarize, and this is particularly relevant to the countries I haven't been able to address, some of the lessons that we've learned from the region include the importance of client-centered design and differentiated service delivery to make services accessible, available, acceptable, and affordable. Convenience is really key, and this includes opening hours and days, locations, the use of mobile clinics. A further example of this is that when Sri Lanka offered PrEP on Sundays, they were able to increase uptake by 50% with that one change. A range of service types and locations really are needed. Malaysia is planning to introduce PrEP in pharmacies on a trial basis initially to really increase access. Key population-led services are often preferred by potential users. Affordable pricing, and I haven't really gone into affordable pricing, but this is really important. What I can say is that countries without subsidized PrEP have lagged in uptake, and this includes countries such as mainland China. And attention is really shifting towards underserved populations, including people who inject drugs. PrEP must be integrated into the national response to HIV for there to be a real uptake and to achieve scale. I mentioned that reframing the conversation and removing legal and social barriers. And this includes anything that restricts access to for PrEP to young people, and can be maybe perhaps not restricted, but testing is. And so this is really important. And that promotion, gain framing messaging, and also supporting training and mentoring a real diverse range of providers who may be really acceptable to communities or who may interact with communities, because people don't necessarily present to a KP-led service, to an HIV service. Their interaction may come at a different point. So it's really important that there are lots of different providers who are skilled to at least know what PrEP is and to refer them to the right place. And COVID-19 has had a lot of negative impacts, but perhaps one of the things that has come out of it is really the innovations that have inspired services to free up resources. And these really need to continue post-COVID. And that includes digital and telehealth, self-sampling, increased use of HIV self-testing, simplifying visits. Nobody needs to spend 3 hours in a clinic. Mobile drug delivery, community pharmacies, these kinds of innovations are really important. And so just a few words before I go, there are new products on the horizon. Everything I've spoken about has been related to oral PrEP. But there are new products. So the dapivirine vaginal ring was recommended by WHO in 2021. It is a female-initiated option for pre-exposure prophylaxis. This is not yet available in the Asia Pacific, but we are looking at acceptability and feasibility quite soon in several countries. The other one, which I'm sure that you've probably heard of, is long-acting injectable cabotegravir, which is a highly efficacious 2-monthly injection. There is a pressing need for implementation studies to be conducted, because at the moment we have 2 phase 3 trials and very limited implementation beyond that. So there's a lot of things that we need to understand better as we're in the process of scaling up CAB-LA as an additional option. These are all about providing lots of options and choices so that people will have access to something, rather than this is not pitting products against each other. And so WHO is expected to release a recommendation on this in next month, actually. And as part of increasing this choice and really trying to offer more choices and improve PrEP programming, advocacy for PrEP availability, accessibility, product choice, guidelines, and approvals, we have also partnered on a survey to understand preferences for PrEP products and services among gay men within our region. So we would highly encourage you to share, to participate if you are eligible for the Asia PrEP survey. Your opinions really do matter. And finally, I just want to let you know about upcoming WHO guidance in 2022. I have already mentioned the upcoming recommendation on CAB-LA. We also will be releasing guidance on simplified and differentiated approaches to oral PrEP, which will include expanded eligibility for ED PrEP to all cis men and trans and gender diverse individuals who are not taking estradiol and who have sexual exposure. Reduced stopping period for daily PrEP from 28 to 7 days, updated kidney function guidance, HBV is no longer a contraindication for ED PrEP, greater support for HIV self-testing for PrEP follow-up as well as initiation, and more information on differentiated service delivery models and those options that are available. We'll also be updating the WHO implementation tool from September, which will include a new PrEP and STI integration module and updates to the other modules, including the clinical module first, to integrate these new PrEP products as well as the guidance. To the organizers, to all of my colleagues and contributors to this presentation, as well as AIDS Concern and all of the PrEP advocates, allies, users, implementers, providers, policymakers, researchers, and communities in Hong Kong. You are the future of PrEP. And so thank you for everything that you have done and that you will do to get PrEP done.